এখন ঠিক আছে পলাশ? পলাশ এখন ঠিক আছে?
স্যার ভালো ছিল।
হ্যাঁ, এখন এখন ঠিক নাই?
স্যার আপনি ওটাতে ক্লিক করেন, আপনার 500টা যেখানে আছে ওটাতে ক্লিক করেন।
কোনটাতে কোনটাতে ক্লিক করব?
স্যার, ভালো আপনি আপনার কি আপনার কাজটা যে ক্লিক করেন স্যার।
এখন কি ঠিক আছে পলাশ? পলাশ এখন ঠিক আছে? পলাশ
স্যার
এখন কি ঠিক আছে?
স্যার একটু ভিউ হলে ভালো হতো। এখন খারাপ নাই স্যার, আপনি শুরু করেন, সমস্যা নাই।
না না, একটু বড় করে কিভাবে দেখানো যাবে এটা তো বুঝতেছি না
স্যার
তাহলে তো।
আপনি লেফট, স্যার আপনি লেফট আপার কর্নারে দেখেন, মানে আপনার হাতের
লেফট আপার কর্নারে ফ্রম বিগিনিং, বিগিনিং থেকে না?
হ্যাঁ ফ্রম বিগিনিং, হ্যাঁ ওখানে দেন স্যার।
ওখানে তো দিচ্ছি তো। এখন এখন
হ্যাঁ স্যার ঠিক আছে
এখন
স্যার। স্যার ঠিক আছে স্যার, হ্যাঁ
হ্যাঁ এখন এখন ঠিক আছে?
এখন ঠিক আছে স্যার।
আচ্ছা, ঠিক, থ্যাংক ইউ।
ঠিক আছে।
Thank you. I think today's topic, the comprehensive overview of hypertension, is an important topic because the hypertension is increasing in epidemic fashion worldwide, and still the patients are not aware regarding the hypertension and its also management. So I think the awareness regarding the screening or shortening of hypertensive patient, risk assessment, and classification of hypertensive patient, as well as counseling regarding lifestyle modification, treatment, follow-up, and adherence to therapy. These are very important whenever we are used to treat a patient. So considering the exam as well as the practical life, I think this class is very important for the training as well as our physicians. I will try to share some information you regarding the definition, pathogenesis, classification, measurement of blood pressure, clinical assessment, relevant investigation, and finally the management, and also some important things regarding hypertensive urgency, emergency, and hypertension in a special situation. So hypertension is defined as the level of blood pressure at which the benefit of treatment unequivocally outweighs the risks of treatment. Researchers define the value at which the treatment of blood pressure or high blood pressure uh, improves the outcomes regarding the prevention of hypertension mediated target organ damage. And so it is the value at which the treatment benefits is more than the risks of treatment. And the blood pressure is a normal physiological thing. This is the pressure exerted by the blood on the vessel wall whenever the blood flows through the blood vessels, and it is exerted at a right angle. And problem is when the blood pressure is increasing above the normal values, that produces certain bad outcomes in relation to the vital organs, especially brain, heart, kidney, blood vessels, and the different hypertension-mediated target organ damages sometimes become life-threatening. So we should know that regarding the pathophysiology and regulation of blood pressure, and you see the certain environmental factors air pollution, noise exposure, ambient temperature. An important thing is lifestyle factors like diet, alcohol, smoking, physical activity, sleep quality, stress, and genetic factors, monogenetic and polygenetic factors. Certain uh, things like gut microbiota, adrenomedullin, adiponectin, prostacyclin, natriuretic peptide, nitric oxide, inflammation, renin-angiotensin system, sympathetic nervous system, endocrine, and so on. The different factors, there is a multifactorial influence in regulation of hypertension, blood pressure. The genetic factors as well as environmental factors both are important in regulation of blood pressure. So whenever we address a hypertensive patient, we should remember regarding the underlying pathogenesis and etiological factors of blood pressure or hypertension, including the lifestyle factors, environmental factors, and endogenous different molecular but endogenous different substances that are responsible for the regulation of blood pressure. And the blood pressure is the end product of cardiac output and total peripheral vascular resistance. And it is the systemic vascular resistance which is very important in increasing blood pressure. So in advancing disease, whenever there is the changes in the vascular wall, atherosclerotic changes and the vessel stiffness increases, the total peripheral resistance is increasing. So in advancing disease, there is chance of raised blood pressure. And sympathetic overactivity, aldosterone, renin-angiotensin system, salt water retention, and different hormonal influences. There is the overactivity of sympathetic nervous system responsible for increasing blood pressure. The hypertension is classified in two types, essential hypertension or primary hypertension and secondary hypertension. And most of the cases, the primary hypertension is around 95%. And in only 5 to 10% cases, we may be able to detect the underlying cause of hypertension. Out of these, important one is, the renal disease like chronic kidney disease, renovascular disease, polycystic kidney disease, and endocrinopathy like Cushing syndrome, pheochromocytoma, thyrotoxicosis or hypothyroidism, hyperparathyroidism, acromegaly. These are the very important causes, endocrine causes of hypertension. And pregnancy, obesity, alcohol, drugs like corticosteroid, NSAID, and sympathomimetic drugs, oral contraceptive pills. These are important etiology behind the secondary hypertension. And another thing, the coarctation of aorta is also important cause of secondary hypertension. And it is one of the important duty of a physician to evaluate a hypertensive patient to knock out the secondary cause of hypertension, especially in a younger one when are presented with hypertension. We should keep in mind that the patient might have a secondary hypertension. So, পলাশ কি শোনা যাচ্ছে কিনা? পলাশ
শোনা যাচ্ছে স্যার, শোনা যাচ্ছে স্যার।
Then the classification of hypertension based on office blood pressure measurement. Blood pressure measurement in office settings or out office settings. In out office settings, it is the home blood pressure measurement, and another is the 24 hours ambulatory blood pressure measurement. In office blood pressure measurement, normal blood pressure is said when the systolic blood pressure less than 130 and diastolic less than 85 millimeter mercury. You see, there is a word and. Both systolic and diastolic should remain within the normal range. That is less than 130 and less than 85 diastolic. And another category is the high normal, whenever the systolic blood pressure 130 to 139 and or diastolic 85 to 89. And hypertension is said when there is grade, the blood pressure is equal or more than 140 systolic and or diastolic 90 or more than 90 millimeter mercury. And grade 1 is 140 to 159 and diastolic 90 to 99. Grade 2, whenever the systolic is 160 or more than 160 and or diastolic 100 or more than 100. This is based on European Society of Hypertension latest guidelines. And we are habituated with the JNC7 classification of hypertension. You see normotensive, one having blood pressure less than systolic 120 and diastolic less than 80. And whenever the systolic is 120 to 139 or diastolic 80 to 89, they are designed as pre-hypertensive ones. And hypertension is said whenever the blood pressure systolic at or above 140 and diastolic at or above 90 millimeter of mercury. And stage 1 is said when there is systolic blood pressure 140 to 159 and or diastolic 90 to 99. Stage 2, systolic 160 or more than 160 and or diastolic 100 or more than 100 meter mercury. And in JNC7, there is another stage 3, there was another stage 3, there is a systolic 180 or more than 180 and diastolic equal or more than 110 millimeter mercury. So it is easy to memorize the JNC7, that is the normal blood pressure less than 120, systolic and diastolic less than 80, pre-hypertensive systolic 120 to 139 and or diastolic 80 to 89, and hypertension at or above 140 and or diastolic 90 or more than 99, more than 90. And stage 1, systolic 140 to 159 and or diastolic 90 to 99. Stage 2, 1 more than or equal to 160 and diastolic more than or equal to 100 millimeter of mercury. These classification depends on British guidelines. Systolic here there is, you see, optimal blood pressure, one thing less than 120, diastolic less than 80, normal less than 130, less than 85 diastolic, high normal another category, systolic 130 to 139 and diastolic 85 to 89. And you see there is 3 grade 1, grade 2, grade 3. Systolic 140 to 159, diastolic 90 to 99, this is grade 1. Systolic 160 to 179 and diastolic 100 to 109, grade 2. And severe one is the grade 3, is 180 or more than 180 and diastolic 1 more than 110. And this is important, isolated systolic hypertension. You see grade 1, 140 to 59 and diastolic less than 90. Grade 2, systolic more than or equal to 160 and diastolic is less than 90. That is, in isolated systolic hypertension, you see the systolic blood pressure is more than normal, but diastolic remains within normal. There is less than 90 millimeter mercury. This is isolated systolic hypertension. So how to measure blood pressure? This is very important because once a patient is described as a hypertensive, he should continue the lifestyle modification or treatment, drug therapy lifelong. So we should measure the blood pressure cautiously, and that is it should be representative blood pressure by a well-validated and well-calibrated machine. Before measuring blood pressure, we should remember certain prerequisites, like we should use a machine that has been well-validated, well-maintained, and properly calibrated. We should measure blood pressure in sitting posture, and sometimes additional standing blood pressure measurement is required in elderly person, in diabetic patient, and patient having possible postural hypertension. In those cases, blood pressure should also be measured in a standing position. We should remove tight clothing from the arm. We should support the arm at the level of the heart. And we should use a cup of appropriate size. We should lower the blood pressure slowly, that is uniformly, and deflation should be done. And we should read the blood pressure to the nearest 2 millimeter of mercury. And phase 5 of Prof sound, that is the disappearance of sound. It is the measurement of diastolic blood pressure. And we should take 2 measurements at his visit. These are the prerequisites to before measuring the blood pressure. And sometimes you may ask in the exam, especially in clinical examination or skill recognition, simply the measurement of blood pressure sometimes you may ask. So you see there is a picture showing the appropriate posture measurement, how to measure blood pressure. In home blood pressure, I have already told you out-of-fish measurement blood pressure that might be done in the home settings or ambulatory blood pressure measurement. And there is also an office blood pressure measurement in chamber practice or in hospital settings. This is the office blood pressure measurement. And in later slide, I will show you there are two entities, the white coat hypertension and mask hypertension. To knock out or to establish the white coat or mask hypertension, this is very important. That is the home blood pressure measurement or ambulatory blood pressure measurement. In home blood pressure measurement, we take two readings with 1 minute interval between, and finally we use average one. In office blood pressure measurement, it is nowadays said that we should take three readings with 1 minute interval between, and finally we average the last two values in office blood pressure measurement. And arm should be bare, resting on table, mid arm at heart level. Legs should be uncrossed, feet flat on the floor. That is, there will be foot rest and sitting with back support. That is the back rest. And we should not talk, even physician or attendant or with the patients also. And patient should be avoidance of smoking, coffee, food beverage, and drug or exercise at least 30 minutes before measurement of blood pressure. And the environment should be remain quite comfortable temperature, quiet room. And first one, important one is that we should use validated and automated electronic upper arm cuff device. That is the blood excimer manometer should be well validated, well calibrated. And patient should remain in relaxed position in sitting posture. That should be foot raised, back raised, and hand should be supported. And the cuff should be placed at the level of the heart. And avoidance of smoking, coffee, and exercise at least 30 minutes before measurement of blood pressure. These are the very important things whenever we use to measure blood pressure. We should remember these things. You see the arm circumference. When the patient arm circumference 20 to 26 centimeter, we should use a small adult cup size. If it is 27 to 34, adult size, 35 to 44, large adult, and 45 to 52 centimeter adult thigh cup size. Blood pressure measurement plan according to the office blood pressure level. If the office blood pressure level less than 130 to 85 millimeter mercury, there is 130 systolic and less than 85 millimeter mercury diastolic, we remeasure within 3 years. And patient having risk factors 1 year, the blood pressure should be remeasured. And in the level systolic 130 to 159, over diastolic 85 to 99, if possible, it should be confirmed with out of office blood pressure measurement. And there is a high possibility of white coat or mask hypertension. Alternately, confirmed with repeated office visits. And if the blood pressure level 160 over 100 meter mercury, 160 systolic and diastolic 100, we should confirm within days or weeks. And another guideline you see, initial blood pressure, if it is normal, you can recheck it in 2 years. If the level is in the pre-hypertensive level, we can recheck in 1 year. And patient having stage 1 hypertension, it should be confirmed within 2 months. And if the patient has blood pressure in the level of systolic 160 or more than 160 and diastolic 100 or more than 100, it should be evaluated or referred to source of care within 1 month. And the patient having blood pressure more than 180 systolic and diastolic more than 110, evaluate and treat immediately or within 1 week, depending on clinical scenario and also the presence of complications. So this is very important slide for follow-up that based on initial blood pressure measurement for adult without acute target organ damage. And whenever we deal with patient with hypertension, we should have a third eye regarding the cardiovascular risk factors. Is common in patient with hypertension. There are some factors that are modifiable and some are relatively fixed risk factors. You see current cigarette smoking, second-hand smoking, diabetes mellitus, dyslipidemia, overweight, obesity, physical inactivity, unhealthy diet. These are the modifiable risk factors. And relatively fixed risk factors are, you see, chronic kidney disease, family history, increasing age, low serotonin status, male sex, obstructive sleep apnea is very important. I think this is a silent killer, the obstructive sleep apnea, having large cardiovascular, producing a large cardiovascular risk. And the psychosocial stress or social deprivation, isolation, these are also important risk factors of the hypertensive patient, considering the cardiovascular outcome. And now the clinical evaluation and assessment of hypertension-mediated organ damage in patients with hypertension. The aim is to establish the diagnosis and grade of hypertension. You know, there is no investigations for diagnosis of hypertension. It is the appropriate measurement of hypertension. This is the diagnosis of hypertension. And it is very important to quantify the severity of hypertension by grading the hypertension and screening for the potential secondary causes of hypertension, identification of factors that are potentially contributing to the development of hypertension, identify concomitant cardiovascular risk factors, and identification of concomitant disease, and establish whether there is an evidence of hypertension-mediated organ damage or existing cardiovascular, cerebrovascular, or renal disease. You know, the hypertension usually asymptomatic until the diagnosis. Hypertension, it remains as asymptomatic, and it is said it is a silent killer. And symptoms usually occur whenever there is target organ damage, or symptoms might be due to the underlying etiology of the hypertension. Usually it remains asymptomatic. Sometimes clinical features may be observed that can give a clue of underlying cause of hypertension. Still, there might be some symptoms of patient having hypertension. Some patient may claim substance pain, shortness of breath, palpitation, claudication, peripheral edema, headache, blurring of vision, noxuria, hematuria, and dizziness. You know, these are symptoms due to target organ damage or might be due to underlying etiology. Key information to be collected in personal, family, medical history of a hypertensive patient. You may be asked in the exam to make a checklist regarding these slides. Risk factors like family and personal history of hypertension, cardiovascular disease, stroke, or renal disease. Family and personal history of associated risk factors like hypercholesterolemia, the smoking history, dietary history, salt intake, alcohol consumption, lack of physical exercise or sedentary lifestyle, history of erectile dysfunction, sleep history, snoring, sleep apnea, previous hypertension in pregnancy or preeclampsia. And history and symptoms of hypertension-mediated organ damage, cardiovascular disease, stroke, and renal disease. Regarding brain and eye, headache, vertigo, syncope, impaired vision, transient ischemic attack, sensory motor deficit, stroke, carotid revascularization, cognitive impairment, dementia. Regarding heart, these are the symptoms like chest pain, shortness of breath, edema, a history of myocardial infarction, coronary revascularization, syncope. Kidney regarding thirst, polyuria, noxuria, hematuria, urinary tract infection, peripheral arteries, and patient history or family history of chronic kidney disease, and history of possible secondary hypertension if the patient are young, that is having a grade 2 or grade 3 hypertension, that is the age less than 40 years, but hypertension in the grade of second, grade 2 or 3 grade hypertensive, or sudden development of hypertension or rapidly worsening blood pressure in older patients. History of renal or urinary tract disease, recreational drug or substance abuse, concurrent therapies like corticosteroid, nasal vasoconstrictor shock, chemotherapy, history of spontaneous or diuretic provoked hypokalemia, episodes of muscle weakness and tetany, the hyperaldosteronism, symptoms such as thyroid disease or hyperparathyroidism, history of or current pregnancy and oral contraceptive use, history of sleep apnea. During history taking, we should remember these things. Also, anti-hypertensive drug treatment like current or past anti-hypertensive medication, including effectiveness and intolerance to previous medications, and adherence to therapy. This is also very important. In physical examination, we should remember the following things like regarding patient weight and height and BMI calculation, waist circumference, and signs of hypertension mediated organ damage like neurological examination, cognitive status assessment, endoscopic examination for hypertensive retinopathy, palpation and auscultation of heart and carotid arteries, palpation of peripheral arteries, comparison of blood pressure on both arms, and secondary hypertension related sign or symptoms should be searched like skin inspection, evidence of neurofibromatosis because it may remain concurrently with pheochromocytoma, kidney palpation for signs of renal involvement, like in polycystic kidney disease, auscultation of heart and renal arteries for murmurs or bruise indicating of aortic coarctation or renovascular hypertension, comparison of radial and femoral pulse to detect radiofemoral delay in aortic coarctation, signs of Cushing disease or acromegaly, signs of thyroid disease. So the signs or symptoms of secondary hypertension should be searched. Now the investigation. আচ্ছা তোমরা কি শুনতে পাচ্ছ আমাকে? কেউ একজন বলো তো শুনতে পাচ্ছ?
শোনা যাচ্ছে স্যার, জি।
Okay, thank you. The investigations, the objectives of investigation, they confirm the diagnosis by obtaining accurate representative blood pressure measurements, identification of contributing factors and underlying causes, assessment of other risk factors and quantification of cardiovascular risk, detection of any complications that are already present, and identification of comorbidity that may influence the choice of antihypertensive therapy. These are the objectives of planning of investigations of a hypertensive patient. Routinely, we should do a urine analysis for presence of blood or protein, glucose, blood urea, electrolytes, and creatinine. You know that in hypokalemic characteristics that may indicate primary hyperaldosteronism, though it may occur in diuretic therapy. The blood glucose, serum total, and LDL cholesterol, thyroid function test, and 12 BBC. And depending on clinical clues, certain other investigations can be performed like chest X-ray to detect cardiomegaly, evidence of heart failure, coarctation of aorta, Ambulatory blood pressure recording, I have already told you, to establish or to knock out the white coat hypertension or mask hypertension. Echocardiography to detect or quantify left ventricular hypertrophy, renal ultrasound to detect possible renal disease. That is the asymmetry of kidney or changes in corticomedullary changes to see. And renal angiography to detect or confirm the presence of renal stenosis. Urinary catecholamines, in few chromocytoma, it may be asked. Urinary cortisol and dexamethasone suppression test, plasma renin activity in aldosterone, Now, whenever we refer a patient with hypertension for hospital-based care, we may be asked in the exam, what are the indications for admission of a hypertensive patient in hospital? Patient in whom secondary hypertension is suspected, younger patient, less than 40 years with grade 2 or more severe hypertension, in whom secondary hypertension should be excluded, patients with treatment-resistant hypertension, patient in whom more detailed assessment of hypertension-mediated organ damage would influence treatment decisions, patients with sudden onset of hypertension when blood pressure has previously been normal, and other clinical circumstances in which the referring doctor feels more specialist evaluation is required. So these are the indication of referring of hypertensive patient for hospital-based treatment. Meta-analysis of RCT shown that a 10 millimeter reduction of systolic blood pressure or a 5 millimeter reduction in diastolic blood pressure is associated with significant reduction in all major cardiovascular events by 20%, all-cause mortality by 10 to 15%, stroke will be reduced by 35%, coronary events by 20%, and heart failure by 40%. And office blood pressure targets for treating hypertensive patient. Target blood pressure reduction is less than 140 over 90 meter mercury. And if the patient is less than 65 years, blood pressure target less than 130 over 80 millimeter mercury, if tolerated. But it should be remembered that it is better to keep blood pressure systolic more than 120 and diastolic more than 70 millimeter mercury. If patient is 65 or more than 65 years, blood pressure target less than 140 over 90 millimeter mercury if tolerated. But consider an individualized blood pressure target in the context of frailty, independence, and likely tolerability of the treatment. And the aim for blood pressure control within 3 months. Depending upon the presence of comorbidity or target organ damage, the target range will be varied. In office blood pressure measurement, in the age group 18 to 65 years, target to 130 or lower if tolerated, but not less than 120. If the patient is having diabetes, target to 130 or lower if tolerated, but not less than 120. In presence of chronic kidney disease, it is less than 140 to 130 if tolerated. In coronary disease, target to 130 or lower if tolerated, but not less than 120. Patient having a stroke or transient ischemic attack, target to 130 or lower if tolerated, but not less than 120. But in advancing ages, you see the patient having is 80 or more than 80 years, target 130 to 139 if tolerated. In diabetes, 130 to 139. In chronic kidney disease, it is also 130 to 139. In coronary arteries, 130 to 139. And in presence of a stroke or transient ischemic attack, it is also 130 to 139. But in all cases, in elderly person, diastolic blood pressure 70 to 79, 70 to 79 is the target blood pressure in office blood pressure measurement. Now, regarding the management of patient with hypertension, the non-pharmacological management is very important, and also the pharmacological management. It is the drug treatment. And best proven non-pharmacological intervention for prevention and treatment of hypertension. Number one is the weight loss, that is the maintenance of ideal body weight, and healthy diet. The dietary advice to stop dietary approaches to stop hypertension. The diet is in fruits, vegetables, whole grains, low fat, dairy products with reduced content of saturated and total fat, reduced intake of dietary sodium, enhanced intake of dietary potassium. These are the non-pharmacological advocacy of the hypertensive patient. And another important thing is the physical activity, and aerobic exercise is very important, and the moderation of alcohol intake. These are the non-pharmacological approaches for prevention and treatment of hypertensive patient. And now the pharmacological management, the choice of antihypertensive drug will depend. It is dictated by the patient's age, ethnic background, although cost and convenience will influence. And response to initial therapy, side effects guide subsequent treatment, and comorbid conditions also have influence on initial drug selection. And in a nutshell, you see, a patient having age less than 55 years, in initial stage, in step 1, we can prescribe a C inhibitor or angiotensin receptor blocker. But if the patient is more than 55 years, in that case, calcium channel blocker, and if it is failed, then step 2, a C inhibitor or ARP plus calcium channel blocker. In step 3, the diuretics will be added. And in step 4, whenever it is designed as resistant hypertension, in that case, angiotensin receptor blocker or angiotensin converting enzyme inhibitor, calcium channel blocker, diuretics, and consideration of further diuretic or alpha or beta blocker. And there is option of seeking expert advice in step 4. Nowadays, it is said that we should start treatment with dual combination in most of the patients. That is preference of single pill combination at any step. And in step 1, it is said that angiotensin converting enzyme inhibitor or angiotensin receptor blocker plus calcium channel blocker or thiazide or thiazide-like diuretic. And in step 2, that there will be triple combination, a C inhibitor or ARB plus calcium channel blocker plus diuretic. And in step 3, that is the true resistant hypertension, as a consideration of consultation of hypertension specialist in patients who are still not controlled. And you see, beta blocker can be used as monotherapy or at any step of combination therapy. And we can start with monotherapy only in selected patients who risk hypertension and blood pressure less than 150/95 millimeter mercury, or high normal blood pressure and very high cardiovascular risk, or failed patient and or advanced stage. In those situations, we can start only monotherapy. Otherwise, it is better to use single pill combination. That is the dual combination in step 1, then triple combination in step 2, and further drugs in step 3. So, what are the drugs used in treatment of hypertension? Diuretics, ACE inhibitor, ARB, calcium channel blocker, beta blocker, combination of alpha and beta blockers, and other vasodilator like alpha-1 blocker, hydralazine, and minoxidil. And there are some mm, compelling indication of using antihypertensive depending the presence of comorbidity. Uh, in alpha blocker, there is compelling indication in benign enlargement of prostate. ACE inhibitor when there is heart failure, left ventricular dysfunction, post-MI, or established coronary artery disease, type 1 diabetic nephropathy, secondary stroke prevention. Angiotensin receptor blocker whenever the ACE inhibitor intolerance, type 2 diabetic nephropathy, hypertension, left ventricular hypertrophy, heart failure in ACE intolerant patient after MI. Beta blockers, MI, angina, and heart failure, calcium channel blocker, dihydropyridine group, older patients, isolated systolic hypertension, rate limiting calcium channel blocker when there is angina, thiazide or thiazide-like diuretics, elderly individual, isolated systolic hypertension, heart failure, secondary stroke prevention. So this is also very important slide. In hypertensive retinopathy, these are the changes. Now the special situations like high blood pressure in acute care setting. This is very important. Sometimes blood pressure is measured in acute care settings to judge vital signs and volume, the status of the patient, rather than the presence or absence of hypertension. And blood pressure values obtained in acute care settings are unlike, or it's not useful. Still, an elevated blood pressure in acute care settings should have a suspicion that the patient has hypertension, and patient should be advised for measuring the blood pressure in outpatient settings for further evaluation. So, in acute care settings, we should not declare a patient as a hypertensive. Rather, he should be advocated for measurement of blood pressure in outpatient setting to establish the diagnosis as hypertensive or normotensive or pre-hypertensive. Because of the lack of precision of blood pressure measurement, like the impact of bed rest, acute illness, medication administration, alteration in the patient's usual diet while in hospital, blood pressures obtained in the acute care setting should not be used to the adequacy of blood pressure control. For example, a patient presented with retention of urine due to other causes. Transiently, we may found that the patient have high blood pressure. But after evacuation of bladder, the blood pressure might be settled down. So in acute care settings, we should wait and first time the acute crisis should be treated or addressed adequately and appropriately. And finally, the patient should be evaluated in outpatient settings to establish whether the patient is in hypertension or not. This is very important. White coat hypertension, untreated condition in which blood pressure is elevated in the office, but it is normal when it is measured by ambulatory blood pressure or home blood pressure measurement or both. And you see around 30 to 40% people with an elevated office blood pressure, but they are normotensive. A significant white coat effect can be seen at all grades of hypertension, but prevalence is greatest in grade 1 hypertension. Another entity is the masked hypertension, untreated condition in which blood pressure is normal in the office, but it is elevated when measured by ambulatory blood pressure or home blood pressure measurement or both. And it can be found in approximately 10 to 20% of patients with a normal office blood pressure. That is the patient having hypertension, but in office blood pressure measurement, he is found that he is normotensive. But whenever their blood pressure is measured in out office setting, they have high blood pressure or hypertension. This is masked hypertension. So in white coat hypertension, the cardiovascular risk is intermediate, and they should remain follow up with lifestyle changes. But in marked hypertension, cardiovascular risk is as sustained hypertensive, and drug treatment may be required aiming to normalize out of its blood pressure. So in white coat hypertension, follow-up is essential. In marked hypertension, treatment may be required to normalize the blood pressure. You know the hypertensive urgencies and emergencies. Blood pressure must be reduced within few hours. This is very important. In hypertensive urgency, there is asymptomatic severe hypertension. Severe hypertension, that is the grade 3 in patient with whom there is no evidence of hypertension-mediated organ damage. There is severe hypertension, but there is no target organ damage. Rarely require emergency therapy. Parenteral drug therapy is not usually required in hypertensive urgency. But in case of hypertensive emergency, there is severe hypertension associated with acute symptomatic hypertension-mediated organ damage. And it can be life-threatening, and it requires immediate intervention to lower blood pressure, usually with IV drug. This is the hypertensive emergency. And you see the hypertensive encephalopathy, hypertensive nephropathy, intracranial hemorrhage, acute aortic dissection, preeclampsia, eclampsia, pulmonary edema, unstable angina, or microinfarction. These are the hypertensive emergencies. And diagnostic workup for a patient with hypertensive emergency is an urgency. The common test fundoscopy, ECG, hemoglobin, platelet count, we see fibrinogen level, peripheral blood film, creatinine, eGFR, electrolyte, LDL, haptoglobin, albumin, creatine ratio, urine microscopy, pregnancy test sometimes in women with childbearing ages. A specific test like troponin, test X-ray, echocardiography, when there is suspicion of heart failure, acute ischemia, acute dissection, CT angiography, CT or MRI of brain, kidney ultrasound, urine drug collection. These are the investigations might be necessary for patient having hypertensive emergency urgency. Initial goal in hypertensive emergency, blood pressure should be reduced by not more than 25%. That is within minutes to 1 to 2 hours. Then toward 160 over 100 millimeter of mercury within 2 to 6 hours. Then further reduction toward a normal blood pressure in next 24 to 48 hours in hypertensive emergency. Blood pressure should be reduced within 1 hour to avoid the risks of serious morbidity or death in hypertensive emergency. Parenteral therapy is indicated in most hypertensive emergencies, especially if encephalopathy is present. Another term is malignant or accelerated phase hypertension. This rare condition may complicate hypertension of any etiology and is characterized by accelerated microvascular damage with necrosis in the walls of the small arteries and arterioles. And there is intravascular thrombosis, And there is the resistant hypertension, you see, failure to reach goal blood pressure in patients. three drug regimen that includes a diuretic. After excluding potential identifiable hypertension, clinicians should carefully explore reasons why the patient is not at goal blood pressure, and particular attention should be paid to diuretic type and dose in relation to renal function. And the causes of resistant hypertension: improper blood pressure measurement, volume overload, excess sodium intake, volume retention from kidney disease, inadequate diuretic therapy, improper blood pressure measurement, also important, certain drugs or other causes like non-adherence, inadequate dose, inappropriate combination, NSAID, cocaine, sympathomimetic drugs, oral contraceptive, adrenal steroid, erythropoietin, and associate condition like obesity is also important, excess alcohol intake. Resistant hypertension, how will you treat? Patient is not controlled with inhibitor ARB plus calcium channel blocker plus diuretic. In that case, if the patient has chronic kidney disease stage 1 to 3, GFR more than equal to 30, in that case, along with this drug, you can prescribe spironolactone or beta blocker or centrally acting drug. If the patient having chronic kidney disease stage 4 to 5, 4 and 5, eGFR less than 30, in that case, chlorthalidone or beta blocker or alpha blocker or centrally acting agent. Another terminology is the refractory hypertension. Some patients medical therapy. 4 or more drugs with complementary mechanism given at maximal tolerated doses under the care of a hypertension specialist. Such patients are referred to as having refractory hypertension. You see 4 or more drugs. And refractory hypertension was defined as the inability to achieve blood pressure control, that is to less than 140 to 90 meters of mercury, despite at least 3 visits to the hypertension clinic over 6 or more months. And in that cases, we should consider renal denervation if eGFR more than equal to 40. This picture showing the renal denervation technique. And certain condition, whenever the patient has hypertension and diabetes mellitus, according to ADA 2023, blood pressure threshold 140/90 meter of mercury, and in high cardiovascular risk patient, our target to achieve blood pressure less than 130/80 meter of mercury, and in low cardiovascular risk patient or patient having portal hypertension, dilatation, high risk of adverse effect, in that case, BP target less than 140/90 meter of mercury. This is very important because most of the diabetic patient have hypertension. So we should remember the target blood pressure. Patient having high cardiovascular risk, target less than 130/80, postal hypertension or elderly individual or high risk of adverse effect, in that case, target is less than 140/90 meter mercury. Drugs are initially inhibitor ARB, calcium channel blocker, thiazide-like diuretic. Patient having albuminuria, inhibitor ARB, and if the ACR more than 300, in that case also AC inhibitor or ARB. You see patient having hypertension with diabetes mellitus, if initial blood pressure less than 160/100 meter of mercury, start with one agent. If albuminuria present, start with senior ARB. No albuminuria absent, in that case, you can start with inhibitor ARB or calcium channel blocker diuretic. And lifestyle management is necessary in all cases. If the blood pressure, initial blood pressure 160, more than 160, and diastolic equal or 100, equal to 100 or more than 100, along with lifestyle modification, we should start two agents in presence of albuminuria, start with acinate or ARB and CCB, the calcium channel blocker or diuretic. Without albuminuria, we should start with out of three to two, there is acinate or ARB, calcium channel blocker or diuretic. Here you see the acinate or ARB is mandatory, acinate or ARB and calcium channel blocker or diuretic. একজন বলো, কেউ শুনতে পাচ্ছ কি?
স্যার শোনা যাচ্ছে স্যার।
শোনা যাচ্ছে স্যার।
থ্যাংক ইউ। Patient having hypertension with chronic kidney disease, the ACE inhibitor or ARB not recommended for primary prevention of CKD with normal ACR. And control of blood pressure and reduction of proteinuria is the main therapeutic target. Usually requires combination therapy, renin-angiotensin system blocker and calcium channel blocker or diuretic. CKD with hypertension. Level of proteinuria if ACR less than 30, that is CKD with no proteinuria. Blood pressure threshold systolic more than 140 or diastolic more than 90. Target blood pressure systolic less than 140 and diastolic less than 90. And proteinuria more than 30 milligram per ACR more than 30 milligram per gram, diabetic or non-diabetic. Our threshold is systolic more than 130 or diastolic more than 80, and target BP systolic less than 130 and less than 80. So chronic kidney disease without proteinuria, our whole systolic blood pressure is less than 140 and less than 90 diastolic, and having ACR more than 30 in chronic kidney disease patient, our target to lower blood pressure less than 130 systolic and diastolic less than 80. ACE inhibitor or ARB are the first choice in presence of proteinuria. ACR more than 300, ACE inhibitor or ARB, both diabetic, non-diabetic. ACR 30 to 300, ACE inhibitor or ARB, only diabetic patient. Chronic kidney disease patient, stage 1 to 3, you see, ACE inhibitor or ARB plus calcium channel blocker or diuretic. Increase to full dose if patient is well tolerated. In step 1, that is the dual combination. If you fail to reach our goal, dose should be increased and another drug should be added, that is a triple combination. And whenever we fail to reach our goal, that is if there is true resistant hypertension, in that case we can add a spironolactone or other drug like beta blocker or centrally acting agent. And in chronic kidney disease stage 4 and 5, that is not on dialysis, whenever the patient is not on dialysis, EGFR less than 30, and step 1 dual combination, ACE inhibitor ARB plus calcium channel blocker or loop diuretic. That is plus loop diuretic. And in that case, when there is GFR less than 30 or stage 4 or 5, in that case, we cannot use spironolactone. In that case, chlorthalidone or other diuretic, loop diuretic, or beta blocker or centrally acting drug. Hypertensive patient having heart failure, our blood pressure target is systolic 110 to 130 millimeter mercury. And in case of heart failure, C inhibitor or ARB, carbidopa beta blocker, carbidopa, metoprolol, bisoprolol, or diuretic, calcium channel blocker. And digoxin can be prescribed. In heart failure patient, hypertensive patient, stage A, patient having high risk but no features with normal ejection fraction, risk factor management is inhibitor of chlorthalidone. Asymptomatic ejection fraction less than 40%, in that case is inhibitor ARB and beta blocker. Patient having overt symptom, is inhibitor or ARB. In advanced stage, in intervention may be necessary, ICD or pacemaker. In hypertensive patient having heart failure with preserved ejection fraction, inhibitor ARB plus calcium blocker diuretic, step 2 triple combination, plus including diuretic. Step 3, consider substitution of an angiotensin system inhibitor by and use of particularly in lower spectrum of heart failure with preserved ejection fraction. Beta blocker can be used at any step of combination of therapy. Hypertension, left ventricular hypertrophy, that is reduction of blood pressure, decreased left ventricular hypertrophy, and AC inhibitor or ARB and calcium channel blocker are more effective. Hypertension, coronary artery disease, I have already told you, every 10 millimeter reduction of systolic blood pressure reduces coronary artery disease by 17%. And our target blood pressure should be reduced less than 130 systolic and less than 80. AC inhibitor and or ARB plus beta blocker step 1, and patient having with angina, dihydropyridine calcium channel blocker, and without angina, another diuretic instead of dihydropyridine calcium channel blocker. And in step 3, further drugs can be added. In with obstructive lung disease, calcium channel blocker, ARB or AC inhibitor, diuretic may be used. Selective beta blocker should be used. Hypertension and stroke, major risk factor for stroke, and anti-hypertensive therapy reduce recurrent stroke. Choice of drug is a inhibitor or ARB or thiazide-like diuretic. In acute stroke, in hemorrhagic stroke, if the patient presented less than 6 hours of symptom onset, blood pressure lowering to less than 140 over 90 millimeter of mercury with IV therapy to avoid hematoma expansion and to improve functional neurological status. And a patient having symptoms more than or equal to 6 hours of onset, in that case, the patient having systolic blood pressure less than 220, a slow and moderate blood pressure reduction with IV therapy over several hours is preferred over intensive lowering to less than 140 over 90 millimeter mercury to reduce hematoma expansion. If the systolic blood pressure more than or equal to 220 millimeter of mercury, a careful blood pressure lowering to less than 180 millimeter over several hours with IV therapy is preferred to intensive lowering to less than 140 over 90 millimeter mercury for improving functional recovery. And in case of ischemic stroke, first consideration whether the patient is eligible for IV thrombolysis or mechanical thrombectomy. In that case, lowering of BP to less than 180 over 105 millimeter mercury and maintain it for at least the first 24 hours after thrombolysis or mechanical thrombectomy. And patients who are not eligible for IV thrombolysis or mechanical thrombectomy, if blood pressure less than 220 over 180 millimeter mercury, abstain from blood pressure lowering during the first 72 hours. If systolic blood pressure more than or equal to 220 over 120 millimeter mercury, moderate blood pressure lowering with IV therapy during the first 24 hours may be considered based on clinical judgment. So, in acute stroke, the blood pressure measurement depends upon the type of stroke, whether the hemorrhagic stroke or ischemic stroke, and other factors, the patient presentation, if it is less than 6 hours or more than 6 hours, or in ischemic stroke, whether the patient is eligible for thrombolytic or mechanical thrombectomy. So it will depend upon the clinical scenario and patient presentation. Another entity is the perioperative management of hypertensive patient. In elective surgery, preoperative screening for hypertension-mediated organ damage and cardiovascular risk is recommended. Avoid large perioperative blood pressure fluctuations. Non-cardiac surgery may not be deferred in grade 1 or grade 2 hypertension. In acute stroke, hemorrhagic stroke and ischemic stroke, already I have told you, in perioperative management, perioperative continuation of beta blocker is recommended. Transient preoperative discontinuation of renin-angiotensin system blocker should be considered. Hypertension in pregnancy, this is also very important. Most common medical problems during pregnancy. It occurs in about 10 to 15% of women. And you know, there are different categories of hypertension in pregnancy. In pregnancy, blood pressure more than equal to 140 over 90 millimeter mercury on 2 separate occasions, at least 4 hours apart. They are declared as hypertension in pregnancy. Pre-existing hypertension prior to pregnancy or occurring before 20 weeks gestation. Gestational hypertension, hypertension occurring after 20 weeks gestation without proteinuria or any other features of preeclampsia. Preeclampsia hypertension occurring after 20 weeks gestation with proteinuria, maternal organ dysfunction, or uteroplacental dysfunction. Eclampsia, generalized seizure in a pregnant woman previously diagnosed with preeclampsia, and hypertension that only occurs in clinical environment is called white coat hypertension. So, pre-existing hypertension, gestational hypertension, preeclampsia, eclampsia, and white coat hypertension, these are the entity woman is in pregnancy, hypertensive pregnancy. What are the antihypertensive drugs that are effective and safe in pregnant lady? You know, the methyl dopa, labetalol, diltiazem, nifedipine, amlodipine, clonidine, doxorubicin, and prazosin. These are the effective and safe medication for hypertensive pregnant lady. And initiation of antihypertensive in pregnancy. All women with persistent blood pressure more than 150 over 95 millimeter mercury. In women with gestational hypertension, pre-existing hypertension, parenthesis gestational hypertension, hypertension with hypertension-mediated organ damage when blood pressure more than 140 over 90 millimeter mercury. সুতরাং ভ্যালুটা 140/90 কমে আসলো যদি এটা জেস্টেশনাল হয় বা প্রি এক্সিস্টিং হাইপারটেনশন সুপারইম্পোজড উইথ gestational hypertension or hypertension is hypertension mediated organ death. Hypertension in pregnancy, drug of choice, I have already told you, methyl-dopal levodopa dextrose blocker, blood pressure target less than 140/90, and prevention of hypertension is pre-eclampsia. For prevention, aspirin 100 to 150 milligram in high to moderate risk of patients. In breastfeeding lady, all antihypertensive drugs are excreted in breast milk at very low concentration. Nifedipine and verapamil considered compatible with breastfeeding. ACE inhibitor are compatible with breastfeeding. ARB are not currently recommended in lactating women because of limited safety evidence. And you see, nice guideline, it said that enalapril and thiazide like diuretic is never better option in lactating women. This is a slide showing follow-up in patient with hypertension. Diagnosis, patient or family history, physical examination, office blood pressure measurement, certain lab test, ECG, cardiovascular risk assessment of hypertension or organ damage, and initiation of lifestyle intervention and drug therapy. And initiation phase during the first 3 months, repeated visits with BP measurements, including virtual visits, verify lifestyle factors and adherence, selected lab test, ECG, as well as drug treatment if necessary, and aim for BP control within 3 months. And that might be asked in the exam in follow-up. What are the things we should remember, or what are the things we should advocate to our patient? That might be a question in exam. The slide showing whenever we can withdraw the drug, or what are the condition, or whenever we can deprescribe. That is, in some low-risk hypertensive patient in whom treatment is accompanied by effective BP control for an extended period, it may be possible to reduce the number and/or doses of drug. BP control is accompanied by healthy lifestyle changes such as weight loss, exercise habit, a low fat and low salt diet, which minimizes the environmental pressure influence. A reduction of medication should be made gradually. The patient's blood pressure should be checked frequently because reappearance of hypertension is frequent and can occur at variable time intervals. There is only within days or weeks, but also possibly after many months. Because of the slow redevelopment of structural arterial changes that favor a blood pressure elevation, patients with high cardiovascular risk, hypertension mediated organ damage, or previous accelerated hypertension should not have their treatment withdrawn. So we can withdraw the drug in a hypertensive patient having long-term control level, as well as patient having no hypertension mediated organ damage, or patient have no high cardiovascular risk. And the drug should be reduced gradually. That is, the number or dose of the drug can be reduced very slowly and gradually. And patient should remain under follow-up because there is chance of recurrence of hypertension or reappearance of hypertension. I think this is today's presentation. I'm trying to share you certain information, especially some latest information regarding the hypertension and hypertension management. If you have any query or any question, you can ask, or if you have any, if you want to any contribution, you can contribute.
কারো কোনো প্রশ্ন
বলা
থাকলে স্যারকে জিজ্ঞেস করতে পারেন, এটা তো অত্যন্ত ইম্পর্টেন্ট একটা টপিক, পরীক্ষা বলেন বা যে কোনো কিছুর জন্য। কোনো কিছু ক্লারিফিকেশন বা কারো কোনো প্রশ্ন থাকলে স্যারকে জিজ্ঞেস করতে পারেন।
আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম আসসালাম।
হ্যাঁ, আপনার পরিচয় দিয়ে প্রশ্ন করেন।
আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম আসসালাম।
জি স্যার। স্যার আমি ডক্টর শামসুজ্জামান হাসান। স্যার আমার কোশ্চেনটা হচ্ছে স্যার, টাইপ 1 ডায়াবেটিক নেফ্রোপ্যাথিতে এসসি ইনহিবিটর, টাইপ 2 ডায়াবেটিক নেফ্রোপ্যাথিতে এআরবি বলা হয়েছে কম্পেলিং ইন্ডিকেশন। এর কারণটা কি স্যার? মানে কি কারণে স্যার মানে দুইটা চয়েস করা হয়েছে দুই রকম?
একটাতে এসি ইনহিবিটর টাইপ 1 এ বলা হচ্ছে এসি ইনহিবিটর, টাইপ 2 তে এআরবি।
না স্যার,
ডায়াবেটিক নেফ্রোপ্যাথিতে স্যার।
কারণটা তো আমার ওইভাবে জানা নেই, কেউ কি বলতে পারবে কিনা?